guys, welcome back to the channel, and today we are gonna see Unit 8, that is Abnormal Labor Assessment and Management. From this chapter you will get only one question, that is for 10 marks, long essay. So totally if you learn this chapter you will be perfect with 10 marks. Cephalopelvic disproportion. In this condition, if you see the pelvic which is present, the diameter of this pelvic will be smaller than the normal, either anterior posterior or transversal or oblique. In any way, the diameter of the pelvic will be smaller than the normal pelvic, which is suitable for delivery. In this condition, we do feel the baby's head is too large or the baby can't fit into the mother's pelvic. It will be very difficult for the delivery process. In this condition, we generally perform C-section, which is the safest mode of delivery in this condition. Cephalopelvic disproportion has two types. One is severe disproportion, another is borderline disproportion. If you see in this severe disproportion, the pelvic is very small. If you see the obstetric conjugative, it should be generally 12 centimeters. This is how an healthy pelvic consists. But here it is less than 7.5 centimeters. And if you see the borderline disproportion, here the diameter of all the angle is almost 1 or 2 centimeters smaller than the healthy one. If you see obstetric conjugator, it should be 12 centimeters, but here it is 9.5 to 10 centimeters. And the inlet of anterior posterior diameter is less than 10, but the inlet of anterior posterior, it should be 11 centimeter, but here in this condition it's less than 10 centimeter. And the inlet of transverse diameter is less than 12 centimeter, but the transverse is here. The transverse is generally 13 centimeters in the inlet, but here it is less than 12 centimeters. Almost 1 or 2 centimeters less in the borderline disproportion. These are the 2 degrees that is seen in cephalopelvic disproportion. Causes of CPD. In that, first, nutritional deficiency. Generally, because of vitamin D, we get rickets. You know what is rickets? The legs will be bow like this. So in this, we have even pelvic defect also. So apart from this, there are other two conditions which occurs because of this nutritional deficiency that leads to CPD. Those are, one is rachitic pelvic and other is osteomalac pelvic. In this rachitic pelvic, if you see, the structure of the pelvic is destructive, that is it's not in the proper condition. And osteomalac pelvic, if you see, here the bone is not in the proper condition. Next, if you see, disease, injury to the pelvic bone. Diseases like arthritis, tumor or polio and injuries like fractures can lead to this condition. And next, developmental defect. Developmental defect can be like high or low asymmetric pelvic. I don't know whether you are so familiar with this word, but apart from this, polio is also in this. While developing, the defect may occur. And large baby size. In this, if you see, the baby is generally large in size. There is no problem with mother's pelvic, but still the baby is very large. It can't pass into that pelvic. So we consider this condition as CPD and we undergo C-section. Abnormal fetal position. In this, the position of the fetal is not normal and we can't conduct a normal delivery with that position. In next section, we'll get to know what are malposition and malpresentation. Problem with genital tract. For example, if the mother has undergone any operation this before that is related to her pelvic region, that is what? Problem related genital tract. These are the causes that leads to CPD. Diagnosis of CPD or contracted pelvic. CPD's, the other name is contracted pelvic. Well, if you see, starting every time on the diagnosis process, we take past history. In past history, we will ask the patient whether she has undergone before delivery process or not. Either if she have been already undergone delivery process, in that delivery process, if she has any risk factor related to CPD, anything, the risk factor can be even that I have been informed that baby is very large, right? The pelvic of mother is okay, it's in the normal form, but the baby was very large, so that's a risk factor also. So like that, any kind of risk factor related to CPD has been undergone or not, we will take the history. Apart from this, any kind of accidents or any kind of injuries or any kind of disease underlined conditions like rickets, osteomalacia, polio, any kind of condition is present in the women or not, we will get to know beginning of the treatment itself. And next we will perform the assessment, that is physical assessment. We will take our measurements, height, weight, vital signs, everything. In the performing process, we will take the height. If the woman is less than 5 feet, then it indirectly indicates the women may have small pelvic. But it's not a problem for every woman. Okay, no need to worry about it. But it may be a problem, only 10%, it may be a problem in later condition. Apart from this, we will see all the joints, mainly hip joints, whether it is in symmetrical conditions or not, whether the joints are okay or not, pelvic is okay or not, everything we will assess their body properly. Apart from this, we will see two conditions, dystocia and dystrophysia. Dystocia is nothing but destructure. Our structure is not in the proper condition. Dystrophia means degenerating cells. In any kind of part of our body, if there is any kind of degeneration, we will note it down also. Assessment of pelvic will be done, but generally it will be done before the labor process, but you can even perform this beyond 37th week, but generally it will be performed at the time of delivery process, that is performed by manually clinical pelvicmetry. Assessment of transversal diameter will be done. It will be performed by the fist method, that is they will place their fist in the anal region and to detect the ischial tuberosities, and by that you will get to know the transversal diameter of outlet. Apart from this, we will perform two things, that is X-ray of pelvicmetry and computer tomograph. In that you will get to know whether the patient has CPD or if he is having, at what condition do they have. Apart from this, we have one main thing, that is abdominal vaginal method. This method is very important in this condition. If you see, the women will be placed in the lithotomy position. Lithotomy position is like this, spreading her legs, the delivery position. In this lithotomy position, when the woman is made to lay down, the person one who is performing will insert their hand, right hand, inside the vagina, and the other hand will be above the ischial spine. Now the person one who is placing his above hand will try to push or downwards direction of the pelvic. If the person is able to push, then there is no disproportion. If he is not able to push, then there is moderate to severe disproportion. The management for the CPD we have based on two things, that is borderline degree or moderate degree and severe degree. For this both, if it is in the preterm, if the baby itself in 7.5 months itself a normal delivery is occurring, that is induction of labor is occurring, then we will perform the normal delivery and we will provide a preterm baby care for that baby. If it's in the full term, then we will go with trial labor first and then we will go with C-section. If trial labor is not working, then we will go with C-section. In this, do remember, in severe degree, we can't perform trial labor. That is, normal delivery is not possible at all. In severe degree, we will directly go with C-section. But in moderate degree, we will try for normal delivery, trial labor. If not possible, then we will go with C-section. What are the uses of trial labor? If you see, we are reducing the C-section chances, we are reducing the pain for the mother, and if you see the disadvantage, that is quite big here. There is a chance of fetal death here, and if this trial labor fails, then the risk for the mother's life is also more. These are the management for CPD. Malpresentation. By knowing malpresentation, I will also join with malpositions also. Like that you will understand way better. In malpresentation, first of all, what is malpresentation? See which part of the baby is visible in the lower pole of the uterus. In this region, in the delivery region, which part of the baby is shown, that is presentation. For example, in this, if you see in this way, the baby's face is visible, so that is face presentation. In this, more like baby's forehead and brow is visible, that is brow presentation. In this, the baby's shoulder and hand is visible, that is shoulder presentation. And in this, if you see compound is nothing but extremities, either leg or hand. Sometimes even hand is also considered compound presentation. And cord is nothing but umbilicus cord. If the cord is interrupting, then that is a cord presentation. Apart from this, we have still two, that is vertex and breech. Vertex is nothing but head. This face and brow can be considered as vertex because head presentation is the first presentation. But whereas you see breech is exactly opposite to it. Breech is the leg lower extremities, this presentation. This will be visible first. Mal presentation is during the delivery, what is visible, like if head is visible, that is head presentation. If leg is visible, that is compound presentation, like that. Mal position is nothing but if baby is facing right side or baby is facing left side, baby is anterior, baby is posterior, baby is lateral or not, in which position the baby is facing, that is mal position. Vertex representation, here you can see the head, and occipital is the position which is visible. The head can be visible, okay. So if the baby is facing this side, that's right. If the baby is facing this side, it's left. And if the baby is facing up, it's posterior. If the baby is facing down, it's anterior. If the baby is facing sideways, that is lateral. These are the things you need to keep in your mind. Here the first position is right occipito anterior. The baby is facing right side, the head is visible, that is occipito, and it's facing downwards right side, right occipito anterior. Straight, it's facing straight occipito anterior. Left occipito anterior. Left occipito posterior, it's facing upwards, see, left side, left occipito posterior. Right occipito posterior, the baby is facing right side and it's facing upwards, it's right occipito posterior. Straight occipito posterior. And here right occipito transverse, left occipito transverse. These are the positions that are seen in the vertex presentation. Face presentation, if you see in this condition, the baby's face will be visible during the delivery section. And if the baby is facing this side, it's left side. If the baby is facing this side, then it's right side. If the baby's head is towards downside, it's anterior. If the baby's face is towards upside, that's posterior. If it's towards sideway, then that is lateral. Let's see the malpositions in the face presentation. Right mento posterior, right side head, that is face is visible mento, and the head is almost facing towards upwards, posterior, right mento posterior. The same way, if you see here, the baby's left side, mento is visible, and the head is facing towards upwards, posterior position, left mento posterior. Right mento lateral, right side, the baby is facing right side, and mento is visible, and baby is placed lateral. Left mento lateral position. Right mento backwards, it's facing backwards, see, anterior position, right mento anterior position. Left mento anterior position. These are the malpositions that is present in the face presentation. Breech presentation, if the baby is facing this side, it's left. If the baby is facing this side, it's right. If the baby's head is facing backwards, see, this baby's head is facing backwards, it's anterior. If the baby's face is facing towards front, it's posterior. Or else if the baby is facing lateral, either this position or this position, it's lateral, okay. First, left sacral anterior position. The baby is facing left side and it's facing backwards. This is left sacral anterior position. Sacral is nothing but the butt part. in this breech presentation, the butt part will be visible at the time of delivery. So this is sacral. Here if you see, left sacral posterior position. The baby is facing left side and it is facing forward. That is left sacral posterior position. Here left sacral lateral position. The baby is facing lateral wise in left side. That is left sacral lateral position. Here right sacral anterior position. The baby is facing backwards and it is facing right side. That is right sacral anterior position. Here right sacral posterior position, and here right sacral lateral position. These are the malpositions that is present in the breech presentation. During breech delivery, we do see only few things like types of breech delivery apart from seeing the positions. That is either the baby is in the complete breech position or frank breech position or footling breech position. See, complete breech position is the baby's legs will be completely folded, there is no extension. But in the frank breech position, the baby's both leg will be extended. In these two conditions, the baby legs, both legs will be in the same condition. Whereas the footling breech position, if you see, one leg will be folded and one leg will be in the extended position. The chances is, if you see, this frankling position is 65%, the complete breech position is 25%, whereas the footling is just 10%. This is how the cases are occurred in the breech presentation. Cause of breech presentation, in this we see the first is the fetus. If the delivery is occurring in the preterm, at that time this breech presentation is seen. Generally more preterms are breech presentation. Apart from this, if there is multiple pregnancy or if the fetus has any abnormalities or any infection, congenital infections can lead to breech presentation. And next, liquor. Liquor is nothing but amniotic fluid, either polyhydramnios or oligohydramnios. Any condition can lead to breech presentation. And then uterine. If there is any defect in the uterus or any kind of tumor is found in the uterus, then that can lead to breech presentation. Placenta previa is the best example that leads to breech presentation. And then pelvic. If there is any destructive, that is the structure is not in the proper way in the pelvic, or any kind of injuries can lead to breech presentations. These are the causes that leads to breech presentation. Management of breech presentation. Generally breech presentation is seen in the preterm babies. Those are like 7.5 months delivery sections. We generally go with C-sections. Apart from this, if there is any kind of underlying disease conditions or any kind of malpresentations, then we will get breech presentations. Like disease conditions like polyhydramnios, oligohydramnios, preeclamptic, placenta previa, these conditions leads to breech presentation. So apart from this, generally in breech presentation we will try to do breech delivery, the normal delivery. If that's not possible, then we will go to C-section. So before conducting the delivery section, we will arrange everything that are required for C-section. Management of breech presentation, the notes will be provided after the explanations. So for the example, let's take the right sacral anterior position. This is the breech presentation. In this presentation, the baby engages in the right sacrum anterior position. In further, due to the flexion and the movement, the baby turns a bit and it comes to the anterior posterior diameter position. And this diameter is also known as barocentric diameter. In further moving on, the butt will be clearly visible, and in this position the doctor tries to take the baby out. If the outlet was not enough, we will even perform episiotomy at this condition, the occurred here, and the baby butt is born by a groin traction action. The baby's butt will be removed out, and do ignore that baby's legs are out here, but actually still the baby's legs are inside the womb. The main purpose of this image is the baby's hand are in the transversal position, that is in this position. This length the baby's hand are present. That's why this image is presented in this way. See, when the baby's butt is born, the baby rotates 1/8 this way. The baby has been rotated. At this rotation, the baby's hand comes to an transversal diameter. And after this, by moving in a lateral way, the baby's legs, lower extremities, will be removed one after the other. And at this condition, we will be interrupted with the umbilicus. On delivery progresses, the umbilicus is removed carefully. With that, the upper extremity, the shoulder, will be removed carefully due to the flexion. And at the final time, the baby's leg will be holded and the birth of the baby will be performed in the upside down position. And this is how breech delivery is performed. Any disturbance or obstacles found during the delivery, then we do use forceps to perform this delivery. Today's topic, preterm birth. Preterm birth is nothing but normally the birth of the baby occurs in around 40 week. But if the birth of the baby occurs before 40 week in the midway, that is around 7.5 months, that is before 37th week of the pregnancy, that is considered as preterm baby. Then in preterm labor, generally the position of the baby is breech position. The causes of this is if there is any infection in the uterus, any placental conditions like placental abrasion or placenta previa, if the cervical muscle is weak, if there is any rupture inside the muscles or membranes, multiple pregnancy, that is 2 or more babies, if the baby is dead inside, intrauterine death can lead to preterm birth. If the fetus has any abnormalities or the female, that the woman has any abnormalities in the uterine, then doctor generally advises to undergo preterm birth. Genetic factors can lead to preterm birth, and any underlying disease condition like hypertension, diabetes, um, thyroid can lead to preterm birth. Apart from this, your lifestyle, the way you live, like if you are smoking or you are living in the smoking environment, if you are living in the unhealthy environment, can definitely affect the growth of the baby and lead to preterm birth. These are the causes of preterm birth. Management of preterm birth. In this, the first thing is to prevent it. How we are going to prevent? When the woman's pregnancy is confirmed, we will advise her to come for a routine checkup or the weekly checkup. At that time, we will take her vital signs, the whole measurements like her height, weight, how the baby is growing, is there any defect or not, like ultrasound will be performed, fetoscopy will be performed, fetus heart rate will be heard. If there is any defect or any condition that is indicating that the birth of the baby may occur in the preterm, we will provide medications and treatment to stop it. Generally, by good diet, good lifestyle, we can stop the preterm and lead it to the full term birth. If this preterm measurements has failed and preterm delivery is occurring and still there is a chance to stop it, like to we can arrest the preterm birth, that is done by giving a complete bed rest. We will advise the mother to not move at all, to be taken full rest. Mainly, there is no action in the lower abdomen. Generally, we will advise the mother to place her leg in the 45-degree upwards. With the bed rest, we will give a drug called a stocolytic drug. It is a drug which stops the uterine contraction. If there is no contraction, then definitely the birth will be stopped. Even this condition is failed and the birth has occurring, that is the labor is started, then at this condition we will manage the labor. And this management of labor is generally done in 2 stages, first stage and second stage. We will discuss it now. And after the birth of the baby, we will give care for the baby in the NICU. Management of preterm labor. In this condition, we will make sure the mother and the baby is healthy, and in the delivery process the baby has no any injury. We will make sure that conditions first. And in this, if you see, birth asphyxia is the common condition seen. We will try to prevent it. In the first stage of labor, we will try to stop it by giving the bed rest, and you already know it. Apart from this, if there is any condition in the mother that normal delivery cannot occur, then we will undergo C-section, and the whole delivery process, whole labor process will be noted down for the further health purpose, like for in the next delivery we will get to know for at what condition the preterm occurred, so we can prevent it like that. In the second stage, if you see, the delivery has progressed, and we will make sure the delivery is very slow and gentle to avoid the injury in the baby. Episiotomy is not really necessary because baby is not really large in size, but it is provided here to avoid the compressions or any injury to the head. Since the baby is not fully developed, so even a small minor mistake can lead to head injuries. Small compressions can lead to head injuries. To avoid those things, we will perform episiotomy. After the birth, we will provide as usual normal care, that is clamping the cord. And if you see hypervolemia and hyperbilirubinemia or the common conditions seen in this preterm baby, we will try to prevent it. And after the birth, we will provide the care to the baby in the NICU section. This is all the management seen in the preterm labor. Prolonged labor. This labor takes more time than the normal labor takes. For example, if you see, generally a normal delivery should occur within 18 hours. That is, if a woman gets now her labor pain, within next 18 hours she should give birth to that baby. If it is taking more than 18 hours, then automatically it's a prolonged labor. But to find whether the labor is going to be prolonged or not, we will not wait for 18 hours. Like, let's wait for 18 hours. If the baby is not born, we will consider it as a prolonged labor. We will not do that. In the middle, the process, by seeing the progress of the labor, we will get to know whether the labor is prolonged or not. Like cervical dilation, the opening of the cervix, the opening of the vaginal opening, we will get to know whether the labor is normal or prolonged one. Within 1 hour at least it should open 1 centimeter. And next is descent. Throughout the delivery process, the baby will be moving out. Baby will be trying to come out. And while baby is trying to come out, automatically cervic dilation will occur, and the baby's head will start to be visible in the vaginal area. That also should be 1 centimeter. Based on this cervical dilation and descent, we will get to know whether the delivery is normal or prolonged labor. How prolonged labor occurs is generally based on these three things. First is power. Based on the woman's power, she should apply force at the time of delivery. Even based on that thing, the delivery process will be affected. If there is any problem in push technique, and if the woman has been given sedative or analgesic, because of that also the women will not have enough power to do push, so maybe that also affects the delivery process. And if you see the passage, that is the pelvic region, if the pelvic has any problem like CPD, android pelvic, and if any pelvic defect or any tumor present in that, or any injury or scars, like if previous delivery has undergone C-section, there will be a scars in that places, even that also affects the delivery and leads to prolonged labor. And next, the passenger, that is the baby. If the baby is too big, it can't come out, or if the baby is in the mal position, mal presentation, even at that condition normal delivery will take time. Apart from this, if the baby has any abnormalities like congenital abnormalities, that also leads to prolonged labor. And next, based on the duration, we can find whether the labor is undergoing normal delivery or prolonged delivery. Like if the woman's delivery, this is first time, this is her first delivery, that is premigravida, then the first stage should occur within 12 hours. That is, for example, at 1 o'clock the woman got her labor pain. Within next 12 hours, the first stage should get completed. That is, the crowning should be done. The baby's head should be visible within next 12 hours. And after 12 hours, within next 2 hours, the baby should be born. This is in the premigravida, the first delivery. In second or third delivery, that is in multigravida, the count is different. In multigravida, the first stage should occur within 8 hours. For example, at 1 o'clock, if the woman has got her pain, within next 8 hours, the crowning should occur. The first stage should get completed. And after that, within 1 hour, the baby should be born in the multigravida. Management of prolonged labor, the very first thing we do is we try to prevent it. If prevention is not possible, the labor has started and it is a prolonged labor, then we will try to find the cause, what is causing the prolonged labor. After finding it, we will try to protect the mother and fetus from getting injured because of that cause. Prevention of prolonged labor. It is generally done in the routine checkups. At the routine checkups, while the scanning times, we will get to know whether the baby is growing correctly or not, or baby is comparatively big than the normal required level. We will get to know the baby is in big size or baby is in the mal position. Like that, a few things we'll get to know, which is an indication for prolonged labor. Apart from this, at the time of delivery, at the beginning, they'll perform a patography. By that, we will get to know the baby's position and presentations. At the time of delivery, to induce delivery, we will administrate oxytocin. If oxytocin is administered too much, then automatically there will be a rupture of membrane because of extra contraction and relaxation. There will be a rupture of membrane. If there is a damage in the passage or the muscle, then automatically the normal delivery takes some time. It leads to prolonged labor. Then after that, we will try to find the cause. Based on the cause, the process of the delivery will be detected. For example, if the cause is very small, like there is a scar, okay, or if there is any, if the mother is dehydrated, in that conditions, normal delivery is quite possible. We will try to perform the normal delivery. If, for example, the pelvic is not in the correct position, like CPD or mal positions of babies in the mal position, mal presentation, then the normal delivery cannot be performed. We will go with C-sections. When we are performing normal delivery, at that time there is a chance of using forceps delivery. Forceps delivery might occur. At that time, there is a chance that baby's head might get injured and there is a risk of infection and risk of injury will get increased. We need to take care of that, and mother might get dehydrated for that fluid, and if there is any pain is seen more in the mother, for that analgesic. And after the delivery of the baby, we will detect the blood level of the mother, and if there is lot of blood is lost, then automatically we will provide blood to the mother, and other things based on the requirement of the mother will be provided. These are the managements of prolonged labor. Shoulder dystocia. In this condition, if you see, it's an obstetrical condition, which means it's a problem to a delivery. In this condition, either one or both the shoulders during the delivery period, the baby's shoulder gets struck and the baby's outcome will not be possible. The normal delivery will be a critical condition. It can be either the baby is large or even the mother's pelvic can be small. Either the condition, the shoulder dystocia is seen. Risk factors of shoulder dystonia. In the history section, if you see, if there is a previous history of shoulder dystonia, then absolutely this time there is a chance that shoulder dystonia may occur if the cause was related to mother. If mother has any underlying disease condition like diabetes, hypertension, that also leads to this condition, and mother has obesity, then definitely that will lead. Antepartum factor is nothing but during the pregnancy when the baby is growing. At that time, if baby is growing too much, that is a macrosomia, big baby size, that can lead to shoulder dystocia. If mother has any underlying condition and overweight gain, definitely. Apart from this, during the delivery time, that is intrapartum factor, we will get to know the pelvic condition. If CPD is present, then normal delivery is not possible. If there is any problem in dilation, that is opening, or if there is any problem related to descent, that is movement, the baby is trying to come out and the baby can't, baby has been failed to come out. If there is a problem in descent and dilation, then definitely this also a risk factor that is related to shoulder dystocia. Management of shoulder dystocia. Okay, if you see, before the delivery is progressing, the baby is not able to get into the pelvic. This is pelvic. The baby is not able to get in because the pelvic is very small. At that time, we will just stop it and we will perform C-section. But just imagine the baby has passed almost midway of the pelvic. The baby's head is visible. The baby's shoulder is struck now. We can't push the baby inside and then perform again. C-section is not possible. At this time, how we are going to manage it? First, we need to stop these three things. That is, we need to stop this push technique because it may cause, may not, actually it causes injury to the mother and the baby. And pull technique is also stopped. And pivoting. Pivoting is nothing but trying to rotate the baby, trying to change the position of the baby by rotating. That also causes injury. We need to stop these three things. We will try to perform episiotomy, that is cut between anal and the that perineal area. Episiotomy will be performed, and after cutting, the doctor will perform Ruben 2 technique. This technique is he will insert his finger and he will catch the posterior shoulder, either the shoulder, arms, and other hand will be in the base. It will be giving the push power. By applying push, the doctor tries to remove one hand and make sure the baby is very delicate. You can't injure the baby's shoulder line. It should be performed in a very delicate manner. One hand, the posterior arm will be delivered, and next the other arm, automatically the normal delivery will be performed. This is the management of shoulder dystocia. Complications of third stage. After the birth of the baby, the third stage starts, that is the removal of placenta is performed here. At the time of removing placenta, there might be an injury to different levels like vulva, perineum, vagina, cervix, uterus, and visceral organ. Visceral organ is quite rare. Because of removal of placenta, the organs getting damaged is not so commonly seen. First, vulva. In vulva, that is nothing but the external reproductive system. In this, you can see there will be lots of tear and bleeding can be seen. This is generally seen because of the use of forceps in delivery section. If the baby is unable to come, if they use any forceps, or if there is any complications and the delivery section was really hard, then automatically the tear in the external reproductive system will be seen. The injury of vulva involves hematoma of the vulva and laceration. Injury in perineum. Perineum is between the vagina and the, this is vagina and the anus. In between the area is known as perineum. Generally, episiotomy is performed here. Without even episiotomy, at the time of delivery, the tear is seen here because of any complications. If the baby's head is too large, or baby in the malposition, we are trying to get it out, or we are using any forceps, because of that condition there will be an injury in this region. And this injury is generally based on degrees, that is 4 degree. First degree is generally a small tears, which is not a big complication. Small tears around the vagina, that is first degree. Second degree is visible tear and heavy blood loss below the vagina, that is second thing. Second degree is below the vagina, heavy tear. Third degree is this tear from the vagina, it is about to reach the sphincter of anus, that is it is going to reach the anus, that is third degree. And fourth degree is it has been reached the anus. In between anus and the vagina there is a cut, that is fourth degree. These are the 4 degrees that is seen in the injury of perineum. Injury of vagina and the rupture of vaginal membrane is known as colporexis, and this is of 2, primary and secondary. If only the vaginal layer is injured, it is primary colporexis. If apart from vagina the injury has been leaded to cervix, vagina is also injured and the injury is leaded to cervix, then that is secondary colporexis. And next, injury of cervix. Injury of cervix is not common, it's very rare, unless in certain conditions injury of cervix can be seen, like if you see in forceps delivery, breech delivery, or any uterine contractions, severe contractions can lead to injury in cervix. Injury in cervix involves cervical laceration and hemorrhage. Injury of uterus involves PPH, retained placenta, cord prolapse, rupture of uterus, which you will be dealing in further sections. Retained of placenta. In the third stage of labor, the removal of placenta will be performed. While removing the placenta, if the placenta is not fully expelled, there is some part of placenta left over in the uterus itself. The doctor tries to remove it. But even after 30 minutes, the doctor is not able to remove the leftover placenta, then that condition is marked as retained placenta. Generally, how placenta gets out is, it gets separated from the uterus membrane, from uterus muscle, the placenta gets disattached by itself, and because of descent action, it moves towards the birth canal and gets expelled. This is how the normally placenta gets expelled. There are few types, or even you can say as causes. There are few types and causes of retained placenta. First you will go this simple adherent placenta. Here the placenta has been lost its capacity to get disattached from the uterus, that is simple adherent placenta. Well, morbid adhesion of placenta is the placenta has been deeply embedded. If you see in uterus wall, the placenta will be attached. It will be very deeply embedded. Embedded in the sense it will get inside. It's very deeply attached that it's unable to get separated. Well, you see this one is placenta retained. The doctor tries to remove the placenta, but half of the placenta will get disattached and there will be few parts of placenta will be remaining. That is the third type. Here the in the first type the placenta doesn't disattach. In the second type, if you see, the placenta will not disattach because of it's deeply embedded. In third type, if you see, the placenta is disattached but only half of the placenta is disattached. How manually the placenta is removed? Before removing placenta, we will perform some things like providing emotional support, medical support, and providing the medication that is prescribed by the doctor, and arranging the equipments or the things that is required for the further treatment. That is for third stage, the removal of placenta, what are the equipments required, we will arrange it before itself. And the safety measure is very important. After arranging all these things, we will perform the removal of placenta, and it is performed in 3 different ways based on the type of the placenta it is present inside. The first method of removal of placenta is by introducing the hand. Here the doctor or the person who perform this procedure will be following all the safety measure first, and then they will insert their right hand inside the birth canal, that is inside the vagina. While inserting, they will, by holding the cord, they will insert and they will move this cord in the lateral wise. While they are moving in this way, inside the placenta's edges, if you see this is placenta, the edges will get disattached, and then with that lateral motion they will pull the placenta. While pulling this method, the uterus which is in this shape may get disshaped. The repositioning of uterus is performed if the uterus has changed its position. This is first method. And the second method is removing of placenta with the support in the fundus. Here, the left hand will be on the top of the fundus. Here they will be holding the uterus. In the right hand, as usual, from as the first method, by moving lateral wise they'll get in, and here a bit changes. They'll try to move in the lateral wise and they'll try to pull by having a force on the fundus. Even at that condition, the placenta is not getting disattached. Then they will use their fingertips to disattach the tips, the edges of the placenta. To disattach the edges of the placenta, they will use their fingers and then they will remove the placenta. This is the second method. The third method of removal of placenta is withdrawing with the hand. See, they will try the first two methods. Even at that method, the placenta is not removed. They will insert their right hand fully and they will remove the placenta by using their hand itself. This is the third type of the placenta removal. Cord prolapse. Cord is nothing but umbilical cord. See, generally in the delivery process, first baby comes out and then the placenta umbilical cord will come out. While in some condition, due to excessive contractions or any other condition, the umbilical cord presentation will come first before the baby gets delivered. While this cord representation has two types. One is occulta cord prolapse. Second is overt cord prolapse. Occulta is nothing but with the baby, beside the baby, the umbilical cord will be visible. Generally, it will not be visible. In normal delivery, only baby's head will be visible or baby's leg, like based on the presentation. If it is normal presentation, baby's head will be visible. If it is in the breech presentation, baby's leg will be visible. But umbilical cord will not be visible. While in this condition, with the visible of baby's head or leg, with that the umbilical cord also will be visible. You can see here in the pic. While second type is overt cord prolapse. In this, before itself the cord will get delivered, in the sense outside the vagina the cord will be present. That is overt cord prolapse. These are the two types of cord prolapse. What are the risk factors of cord prolapse? If there is one or more babies like twin babies, at this condition cord prolapse occurs. Apart from this, in 7.5 months, the presentation of baby umbilical cord placenta is different from the full term baby. So at this time also cord prolapse can occur. If the baby's weight is less than 2.5 kg, then automatically the size of the baby is also very small. So in this condition it may occur. If the baby has any abnormalities at this condition, or else if the presentation of the baby is in the different than the normal one, then at this condition also cord prolapse can occur. If the amniotic fluid present in the stomach is less, then in this condition also cord prolapse can occur. Apart from this, if there is any abnormality in the placenta, if there is any problem in the location of the placenta, the cord prolapse can occur. Diagnosis: ultrasound is performed. Ultrasound is performed to make sure whether the baby is alive or dead. Based on this status, we will come to know further what to do. Like, if the baby is alive and vaginal delivery is possible, then we will perform the delivery with the help of forceps, like low head forceps or high head forceps. If the vaginal delivery is not possible, then we will perform further thing, like not applying more pressure on the cord by reducing the infusion of oxytocin. If oxytocin infusion is stopped, then the contraction of the uterus will be stopped, then the further movement of the cord will be stopped. And apart from this, we will try to insert the cord inside the vagina. That is performed this way. First, we will secure the bladder by filling it with normal saline, and then we will place a pillow under the hip, and then by introducing our fingers into the vagina, we will try to replace the cord into the vagina. And after that, C-section will be performed in a safer manner. This is the management of cord prolapse. Rupture of uterus. Because of excess use of oxytocin and other conditions, the uterine contraction will be excessive. This excessive uterine contraction will cause injury and damage to the uterus, and it will affect the normal delivery, and that is rupture of uterus. This rupture of uterus has been a common symptom for the death of fetus as well as mother. The normal good antenatal care can actually prevent this rupture of uterus. Now, what are the causes of rupture of uterus? If there is any previous scars because of C-section delivery, the previous delivery was C-section, because of that there is a scar, or previously there is an operation, because of that there is a scar and it is not fully healed. Because of it is not fully healed, the uterus will be very weak, and this can lead to rupture of uterus. And next, obstruct labor. If there is anything that is affecting the normal delivery, like there is an object that is blocking the way, like there is a tumor or baby's malposition, malpresentation, can lead to rupture of uterus. And excessive use of drug. If the delivery is not going in a proper way, then automatically oxytocin will be introduced. If it is introduced in the excessive amount, then automatically the uterus movement will be more. CPD. If there is multiple paternity, that is twin baby or more than that, weak scars, malposition, malpresentation, these are the causes of rupture of uterus. Diagnosis: clinical measurements will be taken first, like personal data, height, weight, vital signs, sign and symptoms, everything will be taken. In the section of history, we will get to know any previous surgery is undergone or not. If the woman has undergone any previous surgery, then she has a scar. We need to take care of it. And ultrasound, by that we will get to know whether the baby is alive or not, in which position the baby is present. To confirm this is rupture of uterus, we will perform laparotomy. Treatment is generally C-section. It can be either prenatal birth or full-term birth. In prenatal birth, in the 7.5 month, if mother gets pain and it is rupture of uterus, then we will perform C-section. The baby is born. It can be alive or dead. Both the conditions are quite possible. We will advise the mother to not get conceived for next 1 year. She should not get pregnant for next 1 year. It is because the scar which is present now and the uterus condition should get developed, should get healed. So we will advise the mother to not get pregnant for next 1 year. If it is a full-term pregnancy, then we will perform C-section and we will take care of the mother. In some cases, mother might get shock. For the shock, we should provide immediate treatment. Then blood transfusion should be done. Preoperative care for C-section should be given. If we are suspecting that the patient might get the rupture of uterus, we need to inform all the members about this condition, and we need to provide IV line. Mainly 2 IV lines will be given. The blood for the patient will be arranged, and immediately C-section should be performed. So the patient will be taken to the operation theater. We provide medications for the pain, tears, and sutures will be done. For that, the gentle care will be provided. Good healthy nutrition diet will be provided. These are the managements for the rupture of the uterus. Postpartum hemorrhage, also known as PPH. It is nothing but the bleeding that is occurring in the women from the birth canal after the delivery, that is in postnatal period. If it is more than 500 ml in the vaginal normal delivery, and if it is more than 1000 ml in the C-section, it is considered as PPH. And it has two types, the primary PPH and the secondary PPH. If the bleeding is occurring for next 24 hours, within 24 hours, if the bleeding starts to reduce also, it is primary PPH. If the bleeding has been around 6 weeks, it is known as secondary PPH. Causes of PPH: uterine atomy. It is the failing of the uterus to contract and relax. If the uterus is not contracting and relaxing, we will provide more oxytocin and there will be excessive contraction. Because of that, PPH might occur. And then retained placenta. Retained placenta is even after removing the placenta, there will be few part of placenta still remaining in the uterus itself. Next, failing to progress during second stage of labor. That is, first stage will be occurring successfully, but second stage, the birth of the baby is still not taking place. At that time, we will provide oxytocin and there will be excessive contraction that may lead to PPH. Placenta accreta, it is the failure of separation of placenta from the uterus. From the uterus, the placenta will get separated by itself after the delivery of the baby. But at some condition, it might not get separated, and that failing is known as placenta accreta. Laceration is the injury and the scars, that is laceration. Instrumental delivery, if there is any obstruction or the baby's head is too large, at some conditions we will perform forceps delivery, that is the instrumental delivery. If the baby is very large in size, that condition also PPH will occur. If mother has any underlying disease conditions like hypertension, diabetes mellitus, preeclampsia, these conditions can also lead to PPH. To remember all this, we can actually classify them into these 4 T's: tone, tissue, trauma, thrombosis. Tone is the movement of the uterus. Based on that, we can classify. I'll say it properly. Tissue is related to membrane and tissue. Trauma is the scar, the physical injury. The injury is known as trauma. And thrombosis is the clotting. When there is excessive bleeding, there will be clotting occurring. That is thrombosis. Okay. Based on the tone, if you see here, uterine atony is based on the tone. There is no proper movement. And failure of progress during second stage of labor, it is also based on the tone. There is no proper movement. That is related to tone. This tone can be even further classified as, if there is multiple babies, then like multiple pregnancy, then there will be no proper movement. If there is a polyhydramnios, lack of amniotic fluid can also affect the movement. This comes under tone. When it comes to tissue, it relates to the placenta. Placenta accreta, retained placenta, placenta previa, placenta abruptia, cord prolapse. This all comes under tissues. When it comes to trauma, trauma is forceps delivery, episiotomy will be performed. This instrumental delivery, large size, if the baby is very large size, then instrumental will be performed. Laceration, this comes under trauma. Thrombosis, after every process there will be excessive blood going on, hemorrhage will be seen, blood clot will be seen, that is thrombosis. This is the cause of PPH. PPH can lead to a condition known as hemorrhagic shock, and this condition can actually lead to death. That severe this condition is. Hemorrhagic shock is nothing but an hypovolemic shock. It is caused due to the lack of blood flow, lack of oxygen supply in the body. It leads to hemorrhagic shock. When we cure PPH, then automatically hemorrhagic shock also gets cured. So based on the degree, we can classify the shock. If the blood loss is from around 500 to 1000 ml, it is normal, no need to worry, there is no shock here. While if it is more than 1000 ml, then automatically it is classified into three types. If it is 1000 to 1500 ml blood is lost, then it's a mild one, and at this condition the BP starts to fall. If it is 1500 to 2000 ml blood loss is occurred, then at this condition BP will be around 70 to 80 mmHg, and this is a moderate condition of shock. While if it is more than 2000 ml of blood is lost and it's very severe condition, patient will not able to move from his place and he will not able to talk or consume food. If for everything he will struggle, and it is the severe condition. These are the degrees of hemorrhagic shock. Management of PPH. First we will inspect the area, the reproductive system, to make sure how deep the injury is. Either suture is enough or we need to provide some special care. Sometimes the wound or the injury will be very small, but there will be heavy excessive blood loss. So first we will inspect and then we will provide the treatment. To protect a woman from the shock, we will provide IV fluids. Mainly blood will be provided. Blood transfusion will be done as soon as, and oxygen level will be maintained, and mainly these two, the vital signs, that is BP and urine output. This both will be maintained normally. If there is any fluctuation, we will inform the doctor and will provide medication for the difference. As shock is getting very deeper, the BP will be reducing, and as equally the urine output also will be reduced. So we need to maintain it. Management of PPH is actually divided into steps. The first is assessment, laboratory examination. Blood and urine examination will be performed. In blood, cognitive timing and blood group will be seen. In urine examination, color and volume will be seen. To avoid the shock, IV fluids, oxygen administration will be done, and regularly vital signs and urine output will be monitored. And inspection of the uterus will be done. Mainly how deep the wound it is, either it is healing or not, and any previous history of trauma, that is any previous surgery, C-section, previous C-section, any clotting is present or not, we will inspect. This is step 1. Step 2, based on the condition, the therapy will be performed. Like if it is based on the tone is the reason for the PPH, then massage, compression, drugs will be provided. If tissue that is related to placenta, then the removal will be done and then the treatment will be performed. If trauma it is, then we will find out what kind of trauma it is, how deep, and how to repair it. If thrombin it is a problem, then we will provide anticoagulative drugs. If treatment doesn't work, we will go with surgical method. In surgical method, we will try to repair the laceration, the injuries. If that's not possible, we will remove the part. Either any in which part the injury is seen, that part will be removed. Hysterectomy will be performed. This is the management of PPH in combined with shock. C-section or caesarean section, also known as caesarean birth. It is a surgical birth of the baby where we will cut. The cut is known as a incision. We will cut the mother's uterus and we will take the baby out. When normal vaginal birth is not possible, we will go with C-section. If there is any complications like breech presentation, malpresentation, malposition, or any obstructions, we will go with C-section. And this C-section is performed in various type. This two type is the common one. One is horizontal cut and other is vertical cut. And this T-shape cut is very rarely performed, but still this is also performed. We will perform C-section only if C-section is the healthiest option for the mother to be performed. Indications of C-section. If there is any problem in the structure of pelvic like CPD, or if the muscles are not working properly, the contraction and the relaxation is not in the correct proportion, it will damage the muscles, membranes, and even it affects the baby also. So normal delivery is not possible. Neoplasm obstruction is extra growth of any muscles like tumors are present in the uterus, then normal delivery will affect. Malposition and malpresentation of the baby, and if there is any previous uterine surgery, if there is any previous scar present, it will affect the contraction and relaxation process. Complete or partial placenta previa or placenta abruptia. Any condition related to placenta will affect the normal delivery, like premature separation of placenta, cord prolapse, this condition, and fetal distress. Fetal distress in the sense there is a pressure on the baby, that baby can't breathe properly, or there is a pressure that is leading to injury to the baby, that is fetus distress. These are the indications for C-section. Management of C-section. First, before delivery. When the patient comes to hospital, we will collect the history, previous data, height, weight, vital signs. After collecting personal data, we will inform the patient about the procedure she is about to undergo. Like what are the pains she will undergo physically, abdomen, back pain, private part pain. And emotionally support is very, very important. Apart from this, to reduce the infection chances, we will clean the area and then take the women to the delivery ward. While checking vital signs, do remember there is a lot of chance the woman might get hypotension because of anesthesia. To reduce that, we will give 50% of dextrose in the IV. And next, as a precautionary measure, we will take the mother's blood group and we will arrange the blood before itself. Because due to delivery section, there will be a lot of blood loss. To match that, we will arrange the blood before itself. And before taking her to the delivery ward, we will make sure at what time lastly she had her food, lastly when she drank the water and all. While collecting the previous history and all, we will get to know for what drugs the woman is allergic to avoid it. After delivery, the first hour we will keep on check the vital signs to make sure the mother is okay, there is no any complications. Like for every 15 minutes we will check the vital signs. In second or third hour, for every half an hour we will check the vital signs, and then after hourly checkup is okay. Daily we need to make sure the fundus position is okay, the uterine condition is okay, it's healing, the pain is getting reduced. We need to keep the checkup daily. And after the delivery, that is in postnatal period, leukia will be excreted. We need to check whether the consistency is correct or not, whether the color of it is correct or not, to make sure there is no any complications which might occur later on. Next, dressing. We need to make sure that while dressing, hygiene protocol should be maintained. Because of crossing the hygiene protocols, there is a lot of chance that infection might occur. Even pus formation might occur. So we need to take care of it. And we need to record the urine output, bowel pattern, bowel sound and all. And pain measurements must be done. If pain is increasing day by day rather than reducing, we need to inform about this to the doctor. If patient has any breathing problem like difficulty in breathing or shortness of breathing, we need to immediately inform the doctor about it. And we should make sure that mother and fetus bonding is very good. Like kangaroo mother care, we need to provide kangaroo mother care to make sure the bonding between mother and the fetus is good. This is the management of the C-section. Indication of labor, which means we are initiating the labor, we are starting the labor. The labor is not occurring on its own. We are starting it either by providing oxytocin or other drugs, or by artificially rupturing the membrane. We are starting the labor, that is induction of labor. And here we do have two types, that is elective induction and indicated induction. Elective induction is the patient doesn't have any medical cause or any reason. Just for convenient purpose, the doctor, the physician, one who perform the delivery, will induce the labor. While indicated labor, we perform it to avoid the other high risk complications which may further affect the delivery. To avoid that, we will induce the labor. Maternal indication, if the pregnancy is not occurring on its own on the given date, that is expected delivery date will be already predicted. If it's not occurring on that date, we will wait for 1 week. If it's not occurring on that period, we will induce the labor. Apart from this, if the mother has any underlying disease condition or any condition, then induction of labor will occur. For example, preeclampsia, polyhydramnios, if there is any premature rupture of the membrane, or any previous history of uh, death of the baby inside the womb, if mother has diabetes or any heart or reproductive system problems, or antepartum hemorrhage, that is bleeding before the birth, that is antepartum hemorrhage. This congenital malformation of the baby is actually fetal indication, it's not here. This is maternal indication. Fetal indication is the conditions that is seen in the fetus. If fetus has any problems, like fetus is not in the stable position, or there is a movement restrictions, the baby is not able to move, or else if fetus is not grown properly or fetus is dead, then the fetus can't proceed the delivery. We need to induce the labor. And post maturity, you know, the premature baby, the baby which is born before the due date, that is premature. If the baby is not born on the due date, it is borning after it, that is post maturity. And if mother and baby has different types of RH groups, then we need to induce the labor. These are the conditions at which the induction of labor occurs. Bishop score, based on this score we will get to know whether the delivery process is going in normal condition, or the vaginal delivery is okay, or else we need to find some other mode of delivery, or oxytocin induced is okay, or we need to provide more oxytocin. Everything we will get to know based on this Bishop score. And we have your scores 0, 1, 2, 3, and based on this topics we will calculate the score: cervical dilation, cervical length, consistency, position of the baby, head station and all. Total we have 13 marks. For 13 marks we will calculate. If the patient gets 6 to 13 marks, then the delivery process is okay, it's going in the correct path. While if it is less than that, that is from 0 to 5 score, if the patient get, then the delivery section is not okay, we need to take care of it. First, cervix dilation. When the baby is inside, dilation is opening of the cervix. When the baby is inside the womb, the delivery has started, but still the baby will be inside the womb, so there is no change in the cervix, no dilation. So first will be closed, we will give 0 marks. While further when the baby starts to move on, the cervix starts to open 1 centimeter, 2 centimeter like that. When it starts to open 1 centimeter or 2 centimeter, we will give 1 mark. In further 3 to 4 centimeter it will be opened, at that time we will give 2 marks. In further it will get 5 centimeters and more than that, and baby will be born, at that time we will give 3 score. Next we have cervix length. This is the cervix length. When the baby inside the womb, there is no change in this length. This length will be more than 3 centimeter, or for some patients it will be 3 centimeter. At this time we will give 0 score. When the baby starts to move down, this length of the cervix will get reduced. You can see here, when the baby starts to move, the length of the cervix is reduced. Now the length is 2 centimeter. Now the score is 1. When still the baby starts to move, this 2 centimeter will get reduced to 1 centimeter. At that time we will give 2 score, and further it will get opened up like this, and then the baby will be born. At that time we will give 3 score. Next, consistency. Consistency is how you feel, how the cervix it is. First it will be rigid or firm, like if you touch your nose, tip of your nose, then you will get to know. That is how the cervix will be felt. In further the delivery continues, this cervix starts to become very softening. It will become soft, and then the baby will be born. When the cervix starts to get little bit softer and then softer, we will give based on that score from 0 to 1, 2 and all. Position. If the baby is inside, that is posterior, we will give 0 score. When the baby is in the middle way, we will give it 1 score. When the baby is head is visible, that is anterior, we will give 2 score. Head station. When the baby is inside the womb, at that time it is -3. When the baby's head is visible outside and it is going to born, at that time that score is +2. In the middle way, the score is -2, -1, 0 and all. The baby is inside. At this time it is -3. We will give 0 score. When baby starts to move out little bit, it's here, then the score will be -2. At that time we will give 1 score. When still the baby comes out little bit down, at that time -1. At that time we will give 2 score. And lastly the baby's head will be visible and it is about to born. At that time +1 or +2. At that time we will give 3 score. By calculating all this, you will get Bishop score, and we will get to know what is the condition of the delivery it is. Methods of induction of labor, we have 3 types: medical, surgical and combined. In combined, if you see, Medicine plus surgical is the combined method. In surgical, we have artificial rupture of membrane and the striping of the membrane. Here what happens? The doctor insert his hand inside the vagina. In the circular motion, he will insert his hand inside the vagina. He goes in and he leaks the amniotic fluid. When amniotic sag is removed, amniotic fluid starts to flow, then automatically delivery will get started. This is how surgical method is performed. And medicine, it is very important. Medical method, we have two types. One is oxytocin induction and other one is prostaglandin induction. Oxytocin. See, oxytocin is not the same amount that is given for all women. Based on their condition, based on how the delivery is going on, at that condition we will provide the oxytocin to the patient. We do have an options like 1 unit, 2 unit, 3 unit and 4 unit. We will provide it with 500 ml of solution. We will dilute it and we will provide to the patient. We will provide it in macro drops and micro drops. In macro we do have 8 and 16 drops. In micro we have 30 drops and 60 drops per minute. These drops are calculated per minute. Now what is macro and micro drops? Macro means more, micro means little. From one drop to the other drop, the time is measured how the macro and micro is seen. Like if you see, we have 8 drops, 16 drops. See, from one drop to other drop, we do have time, few seconds we do have. That is macro. But if you see here, 30 drops, 60 drops. In 1 minute, 30 drops. How fast it will be falling? We don't have that time we get in macro. So we have very little time, very little seconds here from one drop to other drop. That is micro drops. So this is how oxytocin is calculated. Prostaglandin is actually available in the gel form as well as in the tablet form. We have three options for it: misoprostol, dinoprostone, dinoprost. This three function mainly is to induce the labor by rupturing the cervix. Now, how the dosage is provided? Transvaginal, that is in the form of gel ointment. 25 microgram will be provided for 3 hours and 4 times it should be provided. Then automatically the normal delivery will start to begin. If it is oral, then 50 microgram will be provided for 4 hours. For every 4 hours it will be given. Then automatically the normal delivery will occur. When it comes to dinoprostone, here we have a dosage. It is an gel form and here 0.5 mg. It will be applied in the cervix region in every 6 hours. For 3 to 4 times after applying it, the normal induction of labor occurs, and this is the management of induction of labor. These are the possible questions from this chapter. Do practice well. This is the end of the chapter. Meet you in the next video. Until then, stay tuned. Bye.